I wanted to first of all say that the Antibiotic Stewardship Committee, which I'm chair of and Dr. Landwang is a co-chair of, meets once a month, and we kind of realized that, you know, given the COVID pandemic, we thought that perhaps we should just make some comments from a therapeutic strategy approach to these patients, although after we go through most of these slides, you're going to see we really have not that much to offer at this point. But I thought from the standpoint of just antibiotic stewardship, it would be a good idea just to give you some thoughts. And I also want to say that MedStar Corporate has developed therapeutic guidelines, and if you go on Starport, they're actually found on Starport, and they were probably initially created about, I'm going to say about a month ago, and I think within the next week or so, and probably maybe within the next few days, you're going to see some major changes to what the initial guidelines were. So we'll just, I think we can go to the background slide, and I think this is really boring for everybody, but I just want to, you know, you're all aware that infection with SARS-CoV-2, the pandemic is really peaking here in the United States, 2.4 million cases plus worldwide. We know that our vulnerable populations are age greater than 65, and it's particularly affecting folks coming from long-term care facilities or nursing homes. And you're very familiar, all of you, with the comorbidities, which include hypertension, diabetes, cardiovascular disease, chronic respiratory illness, malignancy, and obesity. So with that, I'm going to turn it over to Landwang, who's going to talk a little bit about hydroxychloroquine. And the way we divided this up, we're going to review some of the drugs that have been used. We will talk a little bit about some experimental therapies. We're going to talk a little bit about pharmacology issues in the ICU, and then we'll end it with plasma plasma infusions by Dr. Mohanraj. So I'll turn it over to Lon.
Okay, thanks, Dr. Tinton. So as you all may be aware, I know certainly on the call here, Dr. Welton is certainly aware, hydroxychloroquine has been around for a very long time, really since before 1950. You know, toxicity and drug interactions and other issues with this agent have sort of been some of its limitations, right? And after really chloroquine was discovered 7 years prior, hydroxychloroquine, which only really differs pharmacologically by the addition of an extra hydroxyl group, is usually seen as less toxic, and fewer drug interactions, a little more tolerable as well too. So hydroxychloroquine is indicated for things such as rheumatologic illnesses like arthritis and lupus, systemic lupus, erythematosus. Several studies have shown hydroxychloroquine to be very active in vitro against SARS-CoV-2. In fact, 4 to 5 times more active than chloroquine, which is sort of the paradox of when you examine these two agents and their activity against like MERS-CoV and SARS-CoV-1. So it seems to be in this situation, hydroxy seems to be more active against SARS-CoV-2, whereas chloroquine is more active against some of those other viruses from several years back. So how does hydroxychloroquine work? So no one really knows, but it seems to increase the pH, and it alkalinizes the intracellular phagolysosome and sort of prevents fusion of the virion to the healthy human host cell. It thereby inhibits viral replication, glycosylation of viral proteins, uncoating, and transport and release of other virions. Additionally, both chloroquine and hydroxychloroquine are purported to have immunomodulatory and anti-inflammatory properties too, which explains why they're commonly used for a lot of these rheumatologic illnesses and diseases prior to the current understanding with its use in COVID-19. Side effects of hydroxychloroquine are pretty well known, the most prominent being QTc prolongation. Also some CNS disturbances as well, headache, dizziness. I think a couple of case reports recently have reported use in COVID-19 patients having encephalopathy, but also, you know, the illness itself can cause encephalopathy as well too. A lot of GI problems as well too, nausea, abdominal pain, and diarrhea. And of course, hepatic transaminitis is seen in usually less than 1 or 2% of patients, but something that's notable to for the house staff to be on the lookout for. And of course, the question about G6PD deficiency and hemolysis. So currently, the NIH treatment guidelines for COVID-19 were just released within the last several days. They don't recommend routine testing for G6PD deficiency for hydroxychloroquine, but it should be appreciated that this agent can cause that problem, hemolysis associated with G6PD deficiency. Drug interactions, something that both Dr. Timpone and I looked at, and were sort of surprised by this because we didn't know about this before, but hydroxychloroquine inhibits cytochrome 2d6, so it interacts with the P450 hepatic enzymatic system, and it also inhibits important transport protein, P-glycoprotein as well too. So in terms of drug interactions, it implies that you need to be careful when you're using hydroxychloroquine concomitantly with things like SSRIs and methadone, which some of these agents, SSRIs that is, can go through the cytochrome 2d6 pathway. And then also, as it pertains to P-glycoprotein, digoxin, things like amiodarone, and then the novel anticoagulants like apixaban and rivaroxaban go through P-glycoprotein as well too. So there could be some inhibition here that could cause problems, but still a lot more needs to be studied about this. So the pharmacologic data for hydroxychloroquine is rather interesting. And the top of the slide, you can see I've called it of mice and men, and you'll see what that means in a little bit. Hydroxychloroquine has exhibits an EC50, which is the effective concentration, half the effective concentration against the target, in this case, SARS-CoV-2. So the EC50 here is 0.72 micromoles versus chloroquine, which is 5.5 micromoles. You can kind of see there that hydroxychloroquine is many times more active than chloroquine against SARS-CoV-2, as exhibited by the huge difference there in the EC50. And so the reason why what I'm about to show you next is, I call it a chimeric pharmacokinetic computer simulation, is if you know monoclonal antibodies, usually a chimeric monoclonal antibody combines mouse genetic material with humanized genetic material as well too. So this is sort of like the hybrid we have when we look at this pharmacokinetic model looking at dosing for hydroxychloroquine. So when you look at pharmacokinetic parameters from humans, things like drug clearance, the volume of distribution, and so forth, this was derived from human clinical data. On the other hand, when you look at lung penetration of hydroxychloroquine, this is really old data derived from rats. So you're sort of hybridizing and combining both human data, pharmacokinetic data, and also rat pharmacokinetic data as well too. Even so, this is all we have when we look at PK studies for hydroxychloroquine. Several dosing regimens were studied by a group in China, and between 5 to 10 days of duration. The therapy that most of you all are familiar with, which we've been using in just about all of our patients, is 400 milligrams twice a day of hydroxychloroquine as a loading dose, followed by 200 milligrams BID for the ensuing 4 days to achieve a 5-day total duration of therapy. And what happens is hydroxychloroquine actually achieves really high levels in the lung tissue. And again, as I mentioned before, the lung tissue pharmacokinetic model is based off of rat lung epithelial lining fluid and lung tissue. At any rate, if you look at lung tissue hydroxychloroquine levels, these numbers you see on the screen there are a ratio of the free lung tissue levels compared to the EC50. So this ratio, as you can see, with a 5-day treatment versus 10-day treatment, by day 1, day 3, and day 5, you're getting accumulation of hydroxychloroquine in your lung tissue. And then by day 10, you can see that in the 5-day treatment group there, again, 400 milligrams BID for the load, and then 200 milligrams BID for the ensuing 4 days. Between day 5 and day 10, you can kind of see that the lung tissue level basically remains the same. And that partially has to do with the drug's pharmacologic ability to really concentrate really deeply intracellularly and exhibit really, really slow elimination. So when you use for 10 days of treatment, you see by day 10, your lung tissue levels reach 154 times the EC50. But with the 5-day treatment arm, between day 5 and day 10, as you can see, 85.4 for day 5 is the ratio, day 10 is 83.3. It retains really high levels in the lung tissues. And that partially explains why it has a really, really long elimination half-life. In the serum, hydroxychloroquine has an elimination half-life of about 40 days. So just to show you how profound that is. So the current status of hydroxychloroquine, this is information that I think most of you probably understand. March 28th, the FDA gave an emergency use authorization for the use of hydroxychloroquine in COVID-19. Now, there's some confusion about this because even in the lay press and the newspapers, people don't understand. Even a couple of clinical studies, I think they must have just, they were ill-advised, but they put comments in there that hydroxychloroquine is FDA approved for COVID-19, and that's just not true. A rigorous FDA approval process means that the drug has to be proven to be shown to be both safe and effective. This has not been done. So an emergency use authorization is completely different from that. Just wanted to emphasize that. The only in vitro data that we have, this is what has basically spurred the process for this emergency use authorization. Also, some small uncontrolled clinical trials. And then the data that I just showed you earlier about the dosing for hydroxychloroquine as well, too, is some of the information that the FDA used to make their decision for this emergency use authorization. As all of you are very well aware, there's really no reliable clinical data yet from well-controlled, multi-center, placebo-controlled trials looking at any therapies for COVID-19 treatments. As recently as April 22nd, I looked, which was just yesterday, and there's now well over 100 registered clinical trials for hydroxychloroquine if you just look at clinicaltrials.gov. And with that in mind, many millions of hydroxychloroquine tablets from the strategic national stockpile has been sent to major metropolitan areas, including Washington, D.C., New York, Philadelphia, Detroit, Chicago, and so on and so forth. The recent clinical data that really was released within the past couple of days has really been compelling and somewhat alarming. And 3 publications really from 3 countries, from China, from France, and from the USA, have been released really within the past several days. And all of them have at least been consistent, not in their methodology, but consistent in the results showing that there seems to be no benefit of hydroxychloroquine and possibly higher mortality rates. So this is information that's very disconcerting and very disappointing for sure. The largest study to date, so of these 3 studies that I just mentioned that came out in the last several days, I'm only going to cover the one that was done in the United States because it happened to have the largest patient population. So this study was funded by the VA medical centers and as well as the National Institutes of Health. It's a retrospective study looking at 368 male patients, okay, just male patients because of course they're veterans, collectively all 368 patients that were treated under the VA system. They looked at primary outcomes of death and the need for mechanical ventilation. They used statistical analysis using risk hazard regression and adjusted for baseline characteristics via propensity scores. The time period that was studied was from March 9th through April 11th, 2020, so really just finished, a little over a month's time, and it just finished a couple of weeks ago. I also cited the 2 studies below there, the one done in China and the one done in France as well too, just so you can have some more information. Those studies are usually between 130 and 150 patients. So the study here with the VA was well over double the number of patients enrolled in those trials. But those 2 studies are also important too, as well as looking at hydroxychloroquine and its perceived benefit, or lack thereof, I should say. So what did this VA study show? Well, 3 cohorts here, 3 treatment arms: hydroxychloroquine only, hydroxychloroquine with azithromycin, and then no hydroxychloroquine. So these 3 cohorts here were patients that were looked at retrospectively for clinical outcomes I mentioned for death and then the need for mechanical ventilation. As you can see on the screen there, the mortality rates for the hydroxychloroquine only arm was 27.8% for hydroxychloroquine. For hydroxy plus azithromycin, which is another treatment strategy, that mortality rate was 22.1%. And look at cohort number 3, patients that just got supportive care, only hydroxychloroquine, didn't get, supportive care only, no hydroxychloroquine, that mortality rate was 11.4%, lower than the 2 other patient cohorts that got treatment with what we thought was effective therapy. Their hazard ratio, the second column there, compared to cohort number 3, patients that did not get hydroxychloroquine, was 2.61. And looking at the confidence interval and the p-value there, it did reach statistical significance, with the p-value being 0.03. So these patients that got hydroxychloroquine only were 2.6 times more likely to die as compared to the treatment arm that got no hydroxychloroquine. So pretty compelling information there. And then below that, surprisingly to me for sure, hydroxychloroquine plus azithromycin, which many of the house staff will probably realize with a number of our patients, I would say maybe the vast majority of our folks here that were admitted with COVID-19 and got treated, got hydroxychloroquine with azithromycin. This hazard ratio of 1.14 did not reach statistical significance, as you can see by the p-value being above 0.05 there. But nonetheless, it's somewhat surprising because if you look at mortality, in which QT prolongation, which Dr. T will talk about a little bit later, when you combine these two agents, you increase the risk of QT prolongation. And if mortality, if a group of these patients died from cardiac or cardiovascular-related death, you would think that hydroxy plus azithromycin would increase the risk of that. But in this case, there was actually the hazard ratio did not meet statistical significance in this setting. And then in the third column there, you can see there's a hazard ratio for the risk of ventilation there. There was no statistical significance, 1.43 for the hydroxy-only arm, 0.43 for the hydroxy plus azithromycin arm, no statistical significance there. But nonetheless, I think the mortality data here is the most important to focus on. Okay, and talking about QTc prolongation, hydroxychloroquine, I think most of us have been doing this, and it's been very, very well. This side effect and this complication has been very well is very well in the minds of our physicians and our medical staff here. But for these patients that are getting hydroxychloroquine, it's imperative to obtain a baseline EKG, realizing the difficulty with entering patients' rooms and the infection risk of hooking up a 12-lead EKG. But you always want to try to get a baseline EKG on these folks and withhold hydroxy and azithromycin if the QTc is above 500 milliseconds or the patients have a known history of congenital long QT syndrome. In terms of telemetry, you then want to continue monitoring these patients and certainly DC these agents at the threshold of 500 milliseconds. I think that's a very good clinical pearl to sort of abide by. Make sure their electrolytes are well replenished, so potassium, magnesium levels should be nice and healthy there. So K levels above 4 is what's recommended, mag levels above 2. Avoiding other concomitant medications that can prolong the QTc interval as well too. I listed some examples there. Atypical antipsychotics, especially in the ICU, things like Seroquel, diprazidone, even Zofran, in fact, ondansetron can prolong QTc as well too. So folks that are getting a PRN but really, really high dosage and frequently could pose a risk if the patient happened to be on hydroxychloroquine as well. So the next section here is going to be the big controversy about using, which I sort of talked to earlier, but hydroxychloroquine plus azithromycin. So the data here, Dr. Timpone is going to navigate this data.
Thank you, Len. Let's go to the next slide. Okay, so I call this first slide the hype because I was actually on the wards in mid to late March when we were just starting to see our first few cases of COVID-19 trickle in, and this paper came out from a French group that really reported something that was getting pasted all over social media and the press and everything like that, and got everybody very excited. And so I'll just, going to give you a little bit of a history lesson here. So basically, this was a study. It was an open-label study in hospitalized patients in France, and what they did was they looked initially at 26 patients, and then they picked controls. Now, the controls were really not well defined. Some of them were just patients who didn't want to participate. Some were at other institutions, so there really wasn't a very good control arm. But all that being said, there were 26 patients, and then of the 26 patients, 6 of the patients got excluded from the analysis because of death, ICU, admission, etc. But the bottom line was they decided to give patients, based on the prior data, they decided to give patients hydroxychloroquine at a dose of 600 milligrams a day. So they were giving it as 200 milligrams 3 times a day. And they looked at the rates of virologic clearance of SARS-CoV-2 after 6 days. And what they found was that 70% of patients who received a hydroxychloroquine actually were noted to have virologic clearance versus only 12.2% in the quote-unquote control arm. Then they went back and they looked again and they said, well, some of these patients were receiving azithromycin for bacterial coverage, and they found that of the patients who received azithromycin with hydroxychloroquine, 6 out of 6, or 100%, had virologic clearance. As a result of this, lots of people got excited, and there was a big buzz, and I will say, myself included, again, this was when SARS-CoV-2 just hit, Washington, D.C., and, being an ID doctor and wanting to prescribe something that will help the patient, I became quite interested in this combination. So if we can go to the next slide. So this next slide was from exactly the same group. This is, again, the same group from France, and it was a case series of 80 patients. And the previous study that I just mentioned really didn't give any clinical outcome data. So this was their attempt to say, well, this is our clinical outcome data, and they included 80 patients, actually 6 patients from the previous study, who received, again, 600 milligrams a day of hydroxychloroquine plus azithromycin. Of these 80, one wound up in the ICU, I'm sorry, one died, 3 in the ICU, and actually only 12 of 80 required supplemental oxygen. In this study, they also reported on clinical outcomes, and about 81% were either discharged or went to some other facility. And I'm not really sure exactly what that meant, but they were, I don't know, maybe went to a facility that had less acute care. And again, what they found, 40 of 60 patients who were tested at day 6 had virologic clearance. So they had a reduction in their virologic burden to 0, and so about 66.7% cleared. And clearly it wasn't 100% like they said before, but it was the same regimen, and it was 67%. So if we go to the next slide. So this next slide actually was this was actually the index case at Georgetown. And the reason why I show a sad emoji and the New England Journal of Medicine was because this was the Division of Infectious Diseases' initial attempt at sending a letter to the editor of the New England Journal, because we actually demonstrated in our index case at Georgetown that the patient received the regimen of hydroxychloroquine and azithromycin, and on day 6 after treatment, he still had a positive SARS-CoV-2 PCR. So this was our first thought that, hey, there must be something not right going on here, or at least with the French data. So we were very dubious about the French data. But unfortunately, our letter to the editor got rapidly rejected. It was probably the fastest rejection I ever got. It was within 12 hours. I think we sent it on Friday night, and it came on Saturday morning. But anyway, let's go to the next slide. But after this all occurred, so this is another group from France, and it's a different group. And I'm just going to quickly mention this study because this was another, again, case series only of 11 patients. But these patients had multiple comorbidities, and they also probably were maybe a little sicker than the group. But what they did is they looked at SARS-CoV-2 PCR, giving them the same regimen, azithromycin plus hydroxychloroquine, and what they found was that 8 of 10 patients still had SARS-CoV-2 PCR after receiving the regimen. So again, really in stark contrast to what was reported by the original French group. So we can go to the next slide. So I'm going to quickly go through these next few slides very fast, but I just want to point out a couple of other things that have been reported in the literature. So this was a rather large retrospective study that, to be honest with you, the statistics have really escaped me, but this is a study looking at cardiovascular mortality in patients who received hydroxychloroquine and azithromycin. And they looked at a couple of different groups. They looked at rheumatoid arthritis patients who received HCQ, those who received sulfasalazine, patients who received HCQ plus azithromycin, and those who were prescribed, excuse me. So those who were prescribed hydroxychloroquine and azithromycin. And the bottom line with this study, and I think this is the important thing, what they found was there was a hazard ratio of cardiovascular mortality of 2.19. So again, this study started to address some issues that, Lan had mentioned in terms of, the potential for cardiovascular mortality. It also looked at rates of angina as well as CHF. And again, it sort of suggested that, this combination, when compared to patients who received hydroxychloroquine alone or those who did not receive hydroxychloroquine, when they looked at this study, it really started suggesting that there is potentially a risk of cardiovascular mortality and possibly cardiovascular morbidity, including CHF. If we can go to the next slide. So this next slide is just a little more granular than the other study in that it really looked kind of at a real-world situation. They looked at 84 patients who received the combination, who had SARS-CoV-2 and received the combination of hydroxychloroquine plus azithromycin, sort of in a real-world setting. And they attempted to determine the change in the QTc interval from baseline. And you could see, a lot of the characteristics of the patients. But the bottom line was the baseline mean QTc interval was 435, and the maximum mean was 463. That being said, they also looked at things like concomitant medications that Lan talked about that can also prolong the QTc interval, and you can see the percentages there. I think it's about 11% were on neuropsychiatric drugs that can prolong the QTc interval. But when all was said and done, looking at a QTc greater than 500, 11% of this 11% of these patients had a QTc greater than 500, and then they also looked at things like from 40 to 60 and greater than 60. And as you can see, those who increased their QTc by 40 to 60 is about 18%, and then 12% for those who increased it by greater than 60. So this shows some data that, at least in this study, 11% of their patients had a QTc greater than 500. Now, I will give a shout out to Hagai Mendelson, who's been working on a study with myself, and we actually looked at 44 patients here at Georgetown who were on exactly the same regimen, hydroxychloroquine plus azithromycin, and we actually found our rate is 27% at this point, and this is very, very preliminary data. So we actually found, of the 44, we found 12 of the 44 were actually had a QTc that increased to greater than 500. And then I think if you add in patients who increased by about 60, it goes up to like the low 30s. But again, we're still cranking out that data, and again, shout out to Hagai for putting that together. So we can go to the next slide. And the only thing, and Lan pointed this out to me that I thought was very interesting, and this is a study, I think from 2012, and this was in the New England Journal, and what I just wanted to really point out to you, and looking at the Tennessee Medicaid Society, they looked at prescriptions of azithromycin versus no antibiotic versus ciprofloxacin versus amoxicillin. And again, you could see there is a hazard ratio of 2.88 for cardiovascular mortality associated with azithromycin, which again is higher than the hydroxychloroquine plus azithro, and clearly there are different methodologies there. But the bottom line is azithromycin itself does prolong the QTc. So if we go to the next slide. So as a result of all this, the NIH guidelines, which actually were just published on April 21st, I just throw them up there. I don't want to go through them, but if you go to the bottom, they basically do not recommend the use of hydroxychloroquine or plus azithromycin. And many of the other drugs listed there, like hydroxychloroquine, they really are pushing for them to be studied in the setting of clinical trials. Go to the next slide. And based on all of this, I kind of have a sad emoji, and that's actually my EKG of torsades, because as an ID doctor, I currently feel like I do not have anything to offer these patients. So I'm thinking for the rest of the pandemic, I'm just going to telework and let you guys take care of these patients. Who goes next? Is it?
Remdesivir.
Oh, I'm sorry. Oh, I'm sorry. You got to put up with me for just 5 more minutes. Remdesivir is one of the investigational agents. We can go to the next slide. So let's just quickly talk about the mechanism of action. This is one of the true antivirals for SARS-CoV-2. And the mechanism of action really is the drug is a prodrug. It's metabolized intracellularly to an analog of adenosine triphosphate. It actually inhibits RNA polymerase and has been shown to have activity against filoviruses as well as other coronaviruses. It has activity against SARS. It also has activity against MERS. And in vitro has also been shown to have activity against SARS-CoV-2. This drug, Remdesivir, actually was studied for Ebola, but had some negative results. I have the reference there at the bottom if you're interested in reviewing. But it was actually found to be safe in that study. If we can go to the next slide. This slide, I just wanted to kind of go over the animal model really quickly. The NIH did develop an animal model for SARS-CoV-2 in rhesus macaque monkeys. And what they did was they attempted to look at Remdesivir for treatment of SARS-CoV-2 using this animal model. And they had 12 macaques, 6 received Remdesivir, and 6 controls. And what they did was they infected the macaques with SARS-CoV-2, and 12 hours later they gave the first infusion of Remdesivir and then a placebo to the control group. And actually what they did find in this study, very briefly, is that there was a decrease in the viral titers seen by BAL. So what they did was they did bronchoscopy on these monkeys, and they actually saw a decrease in viral titers in the Remdesivir group, and that happened as quickly as 12 hours after the initial infusion compared to the control group. They looked at clinical outcomes, and 1 of 6 of the Remdesivir monkeys actually had some respiratory symptoms, and all 6 of the controls had respiratory symptoms. And then at necropsy, which occurred at 7 days, they looked at viral burden within the lung tissue in the Remdesivir arm versus the control, and again, it was reduced. Additionally, they looked at evidence of acute lung injury in the 2 groups, and there was less acute lung injury, based on histopathology versus those in the control group. Go to the next slide. So I'm just going to briefly go through this article that showed up in the New England Journal about a week, and maybe it's now 2 weeks ago, that looked at the compassionate use trial. And again, this is a product that's made by Gilead, and it's being studied in clinical trials, but this was kind of our first clinical data that we really had for SARS-CoV-2. And it was a study, they reported really predominantly on 53 patients. And as you can see, 30 of these patients were on the ventilator, 4 received ECMO, and the patients were followed for a mean of about 18 days. We can go to the next slide. And the baseline characteristics, really no surprise here. The median age was 64. 74% of the patients who were in this study, and actually I kind of changed, this is from the article, but I kind of just selected certain things and created this table and made some changes from the manuscript that was in the New England Journal. But I just want to mention that 74% of the patients were aged 50 to, or greater than, from 50 to greater than age 70. 75% of them were men, and again, the comorbidities speak for themselves. The median duration of symptoms prior to the start of Remdesivir was 12 days. And then really this just shows the patient outcomes, and as you could see, 68% of patients had a decrease in their oxygen requirements. You can also see that patients, like 17 of 30 patients on the ventilator were extubated, so about 57%, and 47% of the patients were discharged at the time that this study was published in the New England Journal, and there were 7 deaths. We can go to the next slide. In terms of the adverse effects, just briefly, I think the most notable, there was transaminitis, rash has been reported, diarrhea has been reported, but most of these were, relatively mild. There's a lot of other AEs listed here, and it's kind of hard to determine whether they're truly drug-related or whether it's just related to, the disease process of SARS-CoV-2, things including things like hypotension, multi-organ failure. Go to the next slide. Okay, so, so again, this was just a compassionate use study. I think it really, it's hard to interpret this data because we don't have a control arm, but at least we know that, at least based on animal models and in vitro models, we know that the drug has some activity, and hence I think it's really important that we consider enrolling patients in Remdesivir. There is an expanded access program. They initially had it, then they closed it down, and so now I think it's back up again. And I know Dr. Kumar mentioned to me that we are applying to get Remdesivir for expanded access here, and I'll turn it over.
Okay, thanks, Dr. T. So I'm just going to briefly go over the role of anti-inflammatory agents in COVID-19. Just a couple of words really on steroids. As everyone in the audience probably is aware of, systemic inflammation is a major feature of COVID-19, specifically in settings like ARDS, where the massive inflammation of lung tissue can lead to irreversible damage, diffuse alveolar damage that oftentimes, is unrelenting. So, of course, you have to balance the potential benefit of corticosteroids with, of course, some of the problems with corticosteroids, including the potential for delayed virus clearance, all the adverse effects of corticosteroids from head to toe, immunosuppression, of course, with steroids inhibiting T cells, and then secondary infections that can arise from this immunosuppression as well, too. If you look at the NIH Guidelines, really, which, as Dr. Timpone mentioned, was just released within the last couple of days, their recommendations, steroids, is they don't routinely recommend the use of corticosteroids in patients that have COVID-19. There's still so many questions about it. All of the information on using steroids, just like most of the data with therapies for COVID-19, are retrospective in nature, observational. Most of these studies are not peer-reviewed, as you've seen. But at any rate, the only time when the NIH guidelines say anything about that are proponents for steroids is only in the setting of refractory shock. In this situation, they do recommend steroids over not getting steroids. But in routine use of steroids in general is not recommended by the NIH. They don't have any, saying in the setting of mechanical ventilation with ARDS whether they are for it or against it. So not much help there in terms of the role of corticosteroids. So what about other anti-inflammatory agents? What about IL-6 inhibitors? So this is some stuff that's been really hot in the last several weeks. And now that we're, I think, beginning to understand a little bit more about interleukin-6 and some of the other pro-inflammatory cytokines, IL-6 inhibitors were initially deemed to be sort of like the game changers for treating COVID-19. As we know, IL-6, it's a pro-inflammatory cytokine. It's secreted by monocytes and macrophages, and they're part of the immune response in COVID-19 patients. Of course, when they're secreted in excess, patients can enter a very dangerous situation known as cytokine release syndrome, and therefore there could be a role for anti-IL-6 agents. The three agents that are currently FDA approved that are active against IL-6, let me backtrack. When I say FDA approved, I just mean they're on the market by the US FDA, but not specifically for COVID-19. So these three agents include Tocilizumab, Sarilumab, and Siltuximab. All three of these agents have different FDA indications, but they all have in common that they're anti-IL-6 agents, of which Tocilizumab is the agent that I'll spend the most time on, and we have the most experience with, but it's not saying a lot at the same time. So Tocilizumab inhibits IL-6 receptors, both membrane-bound and soluble receptors. It's got FDA indications for rheumatoid arthritis and giant cell arteritis. At the same time, it's also FDA approved for treating severe cytokine release syndrome associated with CAR-T therapy. As you all may know, CAR-T therapy is immunomodulatory therapy that's sometimes often used for refractory non-Hodgkin lymphoma and certain types of acute leukemias. but our center here at Georgetown has a decent amount of experience with patients that receive CAR T therapy, and this is what we know about, this is how we've gotten experience with using Tocilizumab specifically in this population. Tocilizumab, of course, doesn't come without some risk. It's highly immunosuppressive, so you need to do some baseline tests, rule out TB, so send T-spot tests, send out for an interleukin-6, which, as some of you have seen, takes a long time to get the results for. It takes several days because it's a send-out lab. So you send the IL-6 before you consider using Tocilizumab therapy, but you don't want to delay therapy while you're waiting for this lab to come back. And then other inflammatory markers and labs that you would send as well, too, for Tocilizumab. The initial interest in Tocilizumab was really sparked by a very small case series done in China, in Wuhan specifically, 21 patients who had good responses overall with Tocilizumab. And as I mentioned, these authors and really any of the papers that have been released about Tocilizumab, they seem to be very fervent for the use of Tocilizumab. They claimed that of these 21 patients, they found that they deprivessed and their CRPs normalized very, very quickly. Overall, they had a reduced oxygen requirement for these folks and also resolution of abnormal chest CT findings. They also said that 20 of 21 patients were discharged within 2 weeks. 20 of 21 patients discharged within 2 weeks. Their study was entitled, as you can see in the citation below, Effective Treatment of Severe COVID-19 Patients with Tocilizumab. So severe is in the title, severe COVID-19, but only 2 out of these 21 patients actually received any type of invasive ventilation during their hospitalization. So that's something to be taken, to be considered as well too. And they also claim that 0 patients experienced any type of side effect arising from Tocilizumab as well too. As we mentioned, it's a very profoundly immunosuppressive agent, and that's what they reported. In terms of MedStar guidelines, some of you may have clicked on the main Starport homepage for MedStar, and there's some pretty good guidance. There's a therapeutic guideline for management of COVID-19 that some of the people in this room, all the people in this room, in fact, have contributed to, and as well as other leads within the MedStar system to put together this guideline. It's changing really, day to day, and what I'm told, Dr. Napone let me know this morning that we're due for another change in the next couple of days, probably in light of some of the data that we just presented in the last, 30 or 40 minutes or so. But just letting you know that there's a whole guideline here. I just put up the slide for Tocilizumab, but there's a bunch more available for all of these treatments that we're talking about and overall management for COVID-19 patients. Okay. And next, I'm going to turn it over to some ICU therapeutic pearls from our critical care pharmacist, Nicole Harriott.
Hi, everyone. I'll move up so everyone can hear me. Just wanted to touch base. I know some of what we're doing is not completely different than how we would treat any ICU patient, but we do have some different considerations that we have to do. So my focus will be on our pain, sedation, and paralysis treatment options that we have. Some of the factors that we have to now think about with COVID-19, again, you've probably heard a lot of this in the press, is, and a lot of what I'll talk about, but just kind of how it drives our decisions. So one of the big issues is shortages, as we all probably know. Many of these medications are pain meds, fentanyl, are sedating agents, propofol, benzodiazepines, are all on a national shortage because obviously the demand is much higher than what they typically have to, are able to supply for. So that's something that made us think outside of the box, and you'll see on the next couple slides what agents we're using, how we're using them a little differently, just to be able to keep our supply up and being able to continue to provide. As of now, we still have all of our key agents that we would like to use, but I think it's mainly because of how we're using them and how we're using them a little differently than usual. Other dynamics that we have to think about is population dynamics. Seems like many of the ICU patients that we're seeing, and I think there's just some articles that are coming out right now, big risk factors for them to have more severe cases of COVID include hypertension, diabetes, but also obesity. So many of our COVID-positive ICU patients are considered obese or morbidly obese. So that means doses that we're going to have to be using in these patients of many meds that are weight-based, like propofol, are much higher. Certain agents where it is clinically appropriate, we're trying to use ideal body weight, but many are still based on actual body weight. So we're running through supply a lot quicker than we would just because of the average weight of these patients that we're treating. Age is playing a big part. and it's on both extremes. We have, you know, patients 70 and older, but we are also treating a lot of younger patients who tend to have a higher dependence and a higher ability to use higher doses of sedatives and things like that. Also on top of that, there is their past medical history. We have to take into account things like whether they're on sedatives or other agents at home already, their past medical history. Patients who have dementia, delirium, things like that already are going to require different agents. Other things we are doing is, you know, in a typical ICU patient, the nurse is going in and out of the room. For our COVID-positive patients, we're trying to minimize the amount of times the nurse has to go into the room. So we're trying to decide on agents that don't require as much manipulation or monitoring. Also, the fact that these patients are so isolated, it leads to some of our non-pharmacologic methods that we treat these patients in regards to sedation. For instance, redirection. Many times if the nurse is in the room or a family member can be there, we can redirect them if they're suffering from delirium. But a lot of times, unfortunately, these patients are alone, and so we don't have those options. And then again, too, we don't typically paralyze as much as we are now. We don't keep them at such a deep level of sedation, but again, because of this disease state and damage it's causing on the lungs and the need for higher levels of ventilation, we're now having to provide more levels of sedation. Just a reminder, these deeper levels are honestly sedation and paralysis in general, reduces oxygen consumption and energy expenditure, minimizes the stress on the body, helps us to be able to care for these patients, provide procedures, the nurses to care for them, improves ventilation, and what we're using especially paralysis for is ventilation synchrony. And then also from a patient standpoint, keeps them safe, preventing them from extubation, self-extubation, and also keeping our associates safe from harm to them. Unfortunately, though, with using these higher levels of sedation and paralysis, it's leading to longer time on the ventilator, longer time in the ICU and in the hospital, and then which is putting a strain, obviously, on the demand of ventilators that are needed nationwide and also here, and also ICU beds. But also with paralysis, it leads to long-term myopathy we have to worry about. So this is now talking about placing these patients in long-term care facilities, rehab centers, things that we may not typically have to think about. As mentioned already on Starport, there are guidelines and just some references, and including our pain sedation and neuromuscular blockade. There is a link on there that you can see this table and other information. A couple things to point out. Again, our go-to is fentanyl, for instance, for pain, when we're treating pain. But again, if we had every patient on the high doses of fentanyl we probably need, we would be probably out of fentanyl by now. So we're thinking outside of the box. We're also already starting to use dilaudid if needed, and also going to IV pushes rather than continuous infusions as much as possible, and even going to oral agents if needed. We've tried this already on some of our patients that are a little more stable but still need pain treatment and things like that. Oxycodone, even immediate release, can be given every 4 to 6 hours, so less time in the room for the nurse manipulating, but also around the clock that can provide pain treatment and not having to use the IV continuous infusion. I'll talk a little bit more about ketamine, but we are using a lot more ketamine for pain and sedation, which is great because of its dual mechanisms. And then again, when needed, whether it's for ventilation, occasionally for proning, we are paralyzing these patients. And we'll talk a little more, but instead of doing continuous infusions, we're trying to do boluses to allow our supply to last a lot longer than what we would if we did just continuous infusions. So in regards, again, we've talked a lot. I think everyone probably has been exposed to opioids before, but one pain and sedative that's probably not that commonly used is ketamine. This agent has quite a few mechanisms of action and honestly is not fully understood, but one of the big areas is it's an NMDA receptor antagonist. And remember that NMDA receptor is responsible for carrying electrical signals from the body through to the brain to allow for pain to be felt. One of the great benefits of this agent is it blocks that and actually can reset your pain receptors. So you may not even need any pain meds at all, or if anything, a lot lower. It also, at different dosages, has different anesthetic benefits. So at much higher doses, it can provide sedation and deep enough sedation that we may need. So this one agent could take the place of multiple other agents, or at least be used with much lower doses. So dosing is there because most of us are familiar with the pain dosing, but we're going to be using a lot higher doses than we have so far, so you'll see those there. It must be written in milligrams per hour, even though it's dosed in milligrams per kilogram, just by the ability that we have to write, or for the nurses to administer. And it says we can make adjustments every 90 minutes, but we don't typically have to make it that often. Normally every couple hours, if you're increasing or decreasing the ketamine, the patients tend to do very well. Also, though, we're definitely not doing boluses. That's where you lead to a lot of the side effects, the hemodynamic instabilities that we're trying to prevent. Overall, pretty well tolerated. What you'll probably have heard of before is the the hallucinations, the nightmares, the delirium. That side is where we would worry about. To treat some of those, you could have PRN benzos like midazolam, but on top of that, it also can cause hypersalivation. So a lot of times they might need a PRN glycopyrrolate order also. From there, again, if more levels, if paralysis is needed, this is where we've really made a change. Our go-to prior to COVID-19 was cisatracarium drips. Benefit of that is it uses Hoffman elimination, so it does not require any organ for elimination. So no clearance is needed from the kidneys or the liver, which is great. The problem, though, is if we had every single patient on a cisatracarium drip, we would be out of supply already. And so you can only imagine that that wouldn't be a great option. So we've looked into other methods, and one of the big things we're trying to work really well is doing bolus doses of agents that tend to last a little longer, like vecuronium or rocuronium. Our go-to right now is vecuronium, weight-based 0.1 milligram per kilogram up to a max of 10 milligrams. It says every 2 hours PRN. Typically, once you get that in the system, they don't typically need more than 3 to 4 doses a day. So it prevents the nurse from having to be in the room or even on the pump outside of the room making adjustments continuously like they would with a cisatracarium. I think the key to these, though, is remember we're dosing these based on ventilator dysynchrony, not on our true train of 4, what we would do before. So we're really just basing it on what we're using it for, which then also can minimize. Downside to these agents, though, especially vecuronium, does have active metabolites. So in our liver and kidney failure patients, it's going to last a little longer, which in the long term would be to demise, and obviously can keep them on the ventilator for longer, but in the short term it can help us with decreasing the amount of doses that they would need. Just some additional points to consider other side effects. We are seeing a lot of hypertriglyceridemia, mainly in our propofol infusion patients, but we're actually seeing outside of that, even in patients not on propofol. So it must have something to do with the disease state that we're still trying to understand. We have trialed levocarnitine, because the thought that these patients could have a carnitine deficiency. And so we have trialed it and have seen a couple patients whose triglyceride levels have come down, so that's something to consider. We talked quite a bit about QT prolongation, but it is impacting our ability to sedate, because as Lon mentioned earlier, we would typically, use either typical or atypical antipsychotics, throwing in Seroquel and some of these agents, but we can't when we're using some of these other agents with them, or again, these patients tend to have a prolonged QT just at baseline. And then again, extended time. So even though we've seen a lot of these agents, we're just using them for a lot longer than we typically would because of the disease state and then also the agents that we use. So we just need to keep that in mind when we're choosing agents. So minimizing our benzos as much as possible and our paralytics if possible. I'll turn it over.
So we're going to wrap up with Dr. Mohanraj is going to update us on plasma infusions for SARS-CoV-2.
Okay, thank you. So I think I should be able to finish this on time. So for convalescent plasma, this is not something new. It's something that has been used for a very long time, even before antibiotics in like the early 1900s. It was used, for example, for measles outbreaks and had good efficacy. So it's something that once we had the advent of antibiotics and antivirals, we haven't used it as much, but it does still come up. So more recently, it was used for SARS in 2003, for the 2009 H1N1, and also for MERS. So for the prior evidence related to SARS, that first study is a meta-analysis of 32 studies related to SARS coronavirus and severe. Oh, sorry, still can't hear me? Is that better? Severe influenza. And so this meta-analysis, overall it showed a statistically significant reduction in mortality with an odds ratio of 0.25. So something to be taken seriously. However, you can see there that all the studies were of low or very low quality, lacked controlled groups, and had a moderate or high risk of bias. Of these studies, one that I pulled out, this one, Chang, use of convalescent plasma therapy in SARS patients in Hong Kong, it was a case series, fairly large, 80 patients, and they showed the significant thing to take from this is the timing of the convalescent plasma. They showed that if it was given before 14 days of illness, when they were PCR positive but still seronegative, that it seemed that there was a benefit, higher day of discharge rate by day 22. So that's something that is of interest now, is the timing when we use convalescent plasma for COVID-19. So far, sorry, for the next slide, please. So far, for COVID-19, we've had 3 case series. This first one was published in JAMA. This was the first one, just 5 patients, so pretty small. And what they looked at, so in the donor, so when exposed to a virus, there's 2 major types of antibodies. There's binding or non-neutralizing antibodies. These antibodies basically tag the virus and target it for other immune cells to clear it. And then you also have neutralizing antibodies, and these themselves can also neutralize and clear the virus directly. So there's 2 different antibody levels that you can look at. They looked at both in this study for the donor, and the criteria for these patients was that they had to have severe pneumonia and elevated viral load despite antiviral treatment. And then what they found was their outcomes were the viral load became negative by 12 days, the antibody titer increased, and overall the patients were clinically improved. So they found it to be a positive outcome, but again, it's a very small series. And the other 2 subsequent case series, which is on the next slide, one is just 4 patients, and then the most recent one that has come out is 10 patients. So I won't get into too much detail. All these studies are from China, and basically they all show clinical benefit with improvement in the patients. You can see that the one with 4 patients did include 1 pregnant woman. But the bottom line with these studies is that they're case series. So next slide. So none of these are really efficacy studies, and so that's really what we need is better studies. So right now there's 28 studies on clinicaltrials.gov. 3 of them that I pulled out there are comparative studies. So one is at Stanford in the emergency room setting, convalescent plasma versus placebo. One is at Stony Brook looking at convalescent plasma versus standard plasma, so convalescent plasma from patients who have recovered from COVID-19. And then finally, there is one in Spain as well. That's convalescent plasma versus standard of care without plasma treatment. I'm sure many of you are already familiar that Hopkins is also doing a plasma study, but this is a prophylactic study because there's also been evidence that giving it to patients who have had high-risk exposure can be of benefit. And then now, April 13th, the FDA has allowed for an IND application, an investigational new drug, for patients individually through emergency use, which is something that here at Georgetown we've been looking into. And also there's an expanded use program through Mayo, which Washington Hospital Center is the site for that. So this is something I think that there's still a lot of unanswered questions. The optimal therapeutic dosing is not known, the optimal timing, there's this thought that earlier is better, but that's still not fully answered, but it is something that may show promise. In terms of safety, that's actually one good thing, that overall it is generally quite safe. There is a risk of, infectious disease transmission, but, based on our current blood bank guidelines and procedures, that's very, very low. So that's one good thing. And I think that's it.
Okay. All right, so I think that that's our summary from the Antibiotic Stewardship Committee in terms of therapeutic strategies for COVID-19. It's past 1, right? Yeah. So since it's past 1, if you have any questions, feel free to email us, and we'll be happy to respond to your questions. And thanks for everybody's participation. I want to really thank Lan and Nicole from pharmacy, and also Dr. Mohanraj from my division for putting together these slides on a very, very short notice. And hopefully we didn't confuse you too much, but to be honest with you, I'm still confused exactly what to be doing with these patients.
Thank you so much. Hey, we did have one question from Dr. Reichner, and it was, is all the plasma checked for the presence of neutralizing antibodies?
Yes, so, can you hear me?
Yes.
Okay, so the FDA IND for the emergency use allows that you do not have to check for that because the test is not widely available. Here at Georgetown, my understanding is that we don't currently have that capability. I think that through the Mayo protocol, I think it depends on the site. So I'm not sure actually at Washington Hospital Center if they are doing that, but for now, because it's not a easily available test, it's not being done as standard. But I think that is the ideal, to be able to measure it, and I think for a good clinical trial it would be needed. Because there's other questions, like, because in theory a donor can donate multiple times, and then the question is, if they, when they donate, sometimes it can be used for multiple patients, first of all, and then could they come back and donate again, theoretically, but then you don't really know, like, we don't know yet, like, how long the neutralizing antibodies last, for example. So I think there's even more questions.
Okay, and then the next one, it's not a question, it's really a comment. It's from Dr. Feldman. It's in the absence of a good randomized clinical trial, do what Dr. Sachs says. Don't just do something, hurry up and stand there.
Yeah.
I think that's the bind that all of us are in, and I appreciate the exceptionally thoughtful review of all this this flood of information, and really the need to filter it as to what is the quality, what are the things that we can actually use and take home.